Hello and welcome. My name is Craig Javely. I'm an associate professor of anesthesiology at Emory University in Atlanta, Georgia. It's my pleasure to moderate the SOCCA session at IARS entitled Emergency Airway Management, Past the Tipping Point. I'll now introduce our three expert panelists. First up is Dr. Mary Jarzabowski. She's a clinical assistant professor of anesthesiology at the University of Michigan who practices anesthesiology and critical care medicine at the VA Ann Arbor healthcare system. Her clinical and research interests are emergency airway management and sedation practices during mechanical ventilation. She'll be talking today about why outcomes are not improving in emergency airway management. Dr. Rachel Cotter is an emergency medicine physician who has an academic appointment as an assistant professor in the Department of Anesthesiology at Northwestern University, where she serves as the director of POCUS education. She'll be speaking today about beating the clock by safely extending the apnea time in critically ill patients. Finally, we have Dr. Alok Gupta, who's an assistant professor of anesthesiology at Northwestern University, where he attends in the cardiac surgery, thoracic surgery, and neurosurgical intensive care units. He serves as chair of the Northwestern Memorial Hospital's Pharmacy and Therapeutics Committee and is medical director of the PACU. He'll be speaking today about the choice of induction agent in critically ill patients.
Hi, I'm Mary Jarzabowski, and I'm here today to talk to you about outcomes in emergency airway management. I'm a clinical assistant professor at the University of Michigan, and I practice both anesthesiology and critical care medicine at the VA Ann Arbor healthcare system. I am a former stockholder for Abbott, Pfizer, and Danaher stocks, but none of their products nor any commercial products will be discussed during my presentation today. Today, I hope to help you identify patient risk factors associated with cardiopulmonary arrest and other serious morbidities during emergency airway management. I will then hand over to my colleagues to show you techniques and strategies for trying to mitigate some of these modifiable risk factors to make this procedure safer for our sickest patients. Emergency airway management is, in theory, the same procedure as intubating a patient in the operating room. There's a patient who needs an endotracheal tube and positive pressure ventilation, but everything else is different. And I think this photo really depicts why. At the center of this, there is a patient, although it's hard to see him because of the amount of equipment and people around the bedside. Everything in the room becomes technically more challenging, positioning patients, working around equipment, and you'll see in this picture, one of my residents attempting to get to the head of the bed to gain access for intubation. Similarly, the patients are sicker by default. This patient, as you can see, is already dependent on BiPAP here by the side of the bed, has multiple vasoactive infusions running, has a video EEG monitor running, and also has an LVAD. Putting the patient's story together, this was someone with an LVAD who fell, hit his head, and because he was anticoagulated, developed a subdural hematoma. His mental status became confused, prompting concern for seizures, and an EEG was ordered. And then as his mental status declined further, he was placed on BiPAP to temporize until we could intubate him for airway protection. And he was then on his way to the operating room for evacuation of his subdural hematoma. So the patients by default are very high acuity, and although they do present to the operating room, the procedure itself becomes far more complicated. And then I would like to point out that the people around the bed are also different. So in this photo, you'll see a respiratory therapist and 2 ICU nurses. And these people are incredibly skilled and wonderful at what they do in the ICU, but they're not people who manage airways regularly. So communication becomes then a challenge for these situations as well. So it's no wonder in these high acuity, high pressure situations that outcomes might be vastly different from what we're used to seeing in the operating room. So I wager to say that intubating critically ill patients is the riskiest procedure that we as anesthesiologists perform. It takes an extraordinary amount of our cognitive skills to assess a critically ill patient, often in seconds to minutes, to come up with an induction and intubation plan. To technically execute that plan requires a lot of skill, especially in these situations where positioning and access to airways is suboptimal. And then it takes an extraordinary amount of good quality communication to convey a plan and get through these high pressure situations with a team of people that we're not used to working with. So what complications are we talking about? Well, the data on these complications was patchy for a long time. And even though we in anesthesiology publish on airway management regularly, it's often in elective surgical patients. Publications and research on emergent intubations were few and far between, and a lot of these studies were retrospective in nature and therefore subject to a lot of bias and confounding just based on how data was collected during emergent out of OR intubations. So as these studies started to come forward, you'll start to notice a picture that's being painted. It's more common to have multiple attempts at intubation in an emergent out of OR intubation than we'd see in the operating room. Severe hypoxemia becomes a common theme. And depending on how you define it, the incidence varies, but it's still mentioned frequently. Severe hypotension becomes something that gets a lot of mention, again, with variable definitions, but a frequent theme. Esophageal intubation and aspiration are commonly mentioned, although with this incidence that seems lower. And then alarmingly, there's a rate of cardiac arrest between 2 and 3% in most of these studies. I was pretty alarmed by that number. And it's the equivalent of saying 1 in 40 to 1 in 50 of these patients will suffer a cardiac arrest within 30 minutes of an emergent intubation. But I thought perhaps this is historic data. These studies came often from the early 2000s based on retrospective data. And a lot has changed in the last 20 years of anesthesiology. We have video laryngoscopes readily available. We have waveform capnography. We have advances in monitoring. We have supraglottic airway devices that are more sophisticated. So perhaps this is not relevant. Well, DeYoung and colleagues in 2018 published a study based on more contemporary data. They analyzed almost 2,000 patients who underwent emergent intubation, specifically looking at why some of them suffered a cardiac arrest and trying to glean more data on this outcome. Now, what I will point out is that 2.7% of their cohort still suffered a cardiac arrest. Of those who did have a cardiac arrest, almost a third didn't achieve ROSC at all. And of those who did, they still had a significantly high 28-day mortality. So overall, those who suffer an intubation-related cardiac arrest have incredibly high short-term and long-term mortality. This study was significant because they used a multivariate analysis to try and identify independent risk factors for cardiac arrest. And what they found was that age over 75 and a BMI greater than 25 were both independently associated with cardiac arrest surrounding intubation. Obviously, these are risk factors that we can't modify. However, they did identify 3 risk factors that we can potentially modify: the absence of adequate pre-oxygenation, oxygen saturations of less than 80% prior to induction, and a systolic blood pressure of less than 90 millimeters of mercury were all significantly associated with cardiac arrest surrounding emergent intubation. The biggest and most elaborate study of peri-intubation adverse events came last year, and this is the INTUBE study by Vincenzo Risotto and colleagues. This really was beautifully conducted, a multi-center international prospective cohort study of almost 3,000 patients. The investigators were looking at the incidence of major adverse events within 30 minutes of intubation. They defined a major adverse event as any of the following: a systolic blood pressure of less than 65, and the patient needed only one measurement that low to qualify; a systolic blood pressure of less than 90, and that needed to be for 30 minutes or greater; new or increased dose of vasopressors; a fluid bolus of greater than 15 milliliters per kilo; and oxygen saturations less than 80% at any point in the 30 minutes after intubation; and then cardiac arrest. All of these, I think we would agree, are major adverse events that we would like to avoid for our patients. So what did they find? Well, it's very humbling data. they found that 45% of all patients suffered a major adverse event. 45%. I think that's quite astounding. The most common event was cardiovascular instability, and you can see the rates of how it was broken down there. Very commonly, new or increased need for vasopressors. Systolic blood pressure of less than 90 for greater than 30 minutes affected a quarter of the patients. Fluid bolus was common at 13.5%, and 13.5% of patients had a systolic blood pressure of less than 65 at some point in the 30 minutes after intubation. I think that's quite astounding to think our patients' hemodynamic instability is that profound. Severe hypoxemia, defined again as less than 80% oxygen saturation, happened in just under 10% of patients. And again, cardiac arrest at 3.1% of patients. Now, in this study, alarmingly, of those who suffered a cardiac arrest, 47% did not achieve return of spontaneous circulation. So I think the conclusions I draw from this is that our outcomes are not improving for these patients. This study also looked at secondary outcomes and other adverse events that we are often concerned about. For example, esophageal intubation, difficult intubation, and aspiration of gastric contents. Importantly, although these were far more common than we might see in an operating room population, aspiration was just under 4% of patients. And although all of us try to mitigate this in our patients who need emergent intubation, I think comparing this incidence to that of severe hemodynamic compromise and severe hypoxemia really shows us where our priorities should lie as anesthesiologists managing these critically ill patients. So in conclusion, intubation of critically ill patients is a risky procedure without discernible improvement in outcomes in the last 20 years. The incidence of cardiac arrest remains at 2 to 3%. We now know there are major risk factors for adverse events, including BMI greater than 25, older age, hypoxemia, and hypotension. So now with quality data that gives us real etiologies of adverse events, I think we can all safely conclude that we need more information and better efforts at mitigating hypoxemia and cardiovascular instability in the peri-intubation period. I will hand over to my colleagues now to give you some tips and techniques on how to do that. Thank you.
Hi, my name is Rachel Kadar, and I'm from Northwestern University. Today, I will be presenting Beating the Clock, how to extend apnea time in critically ill patients. I have no financial disclosures. Given that hypoxemia is a risk factor for adverse events, I'm going to discuss how to best avoid hypoxemia. Our learning objective is to recognize the importance of raising mean airway pressure during pre-oxygenation and the utility of non-invasive positive pressure ventilation and high flow nasal cannula to optimize pre-oxygenation and apneic oxygenation. In the OR, when the patient is fully pre-oxygenated and denitrogenated, the time to intubate them before they desaturate to less than 90% is up to 8 minutes. However, having even a moderately ill or obese patient will significantly decrease your time to desaturation to 5 minutes and 2.5 minutes, respectively. Now imagine a critically ill obese patient and your curve changes even further. In addition, oftentimes these patients are already dependent on some form of supplemental oxygen delivery or advanced oxygenation techniques. Critically ill patients will desaturate 25 times faster than healthy controls, with desaturation to less than 85% in 23 seconds. Desaturation to below 70% puts patients at risk for arrhythmia, hemodynamic decompensation, hypoxic brain injury, and death. As important as pre-oxygenation is in routine airway management, it is even more important in emergency airway management. I'm going to show you ways to improve your pre-oxygenation technique so you can lengthen your time to desaturation. When pre-oxygenating a patient, there is another map to think about, the mean airway pressure. Increasing the patient's mean airway pressure improves pre-oxygenation through alveolar recruitment. As you can see on this chart, the goal is to provide enough pressure to open and recruit alveoli without over-distending them. Although you think you are delivering positive pressure with a bag mask valve, when you're assisting the patient's ventilation and pre-oxygenating, your mean airway pressure is actually not high enough to recruit more functional alveoli. Therefore, we recommend you use a PEEP valve when bagging the patient to pre-oxygenate. Let's look at a cadaver video showing the difference between ventilating with and without an increased mean airway pressure, which is achieved with a PEEP valve. Here you can note the alveoli collapsing between each breath. Now a PEEP valve is added. Here with the PEEP valve, we increase the mean airway pressure and you can visualize the improved alveolar recruitment. Another way of improving your mean airway pressure is with non-invasive ventilation. We are all familiar with CPAP, but seen more frequently in the ICU is BiPAP as a way of improving oxygenation, increasing minute ventilation, decreasing work of breathing, and starving off intubation. The main indications for BiPAP started as COPD exacerbations and pulmonary edema, but now we use it for much more. This is a busy slide, but the point is to show that there are multiple studies that support the use of increased mean airway pressure as a pre-oxygenation technique. Studies show a 40-second increase in time to desaturation. It can extend SpO2 time greater than 90% by a minute, and it can prolong non-hypoxemic apnea by more than 2 minutes. All of these studies show an increase in apnea time that we will extrapolate will mean less hypoxemia and therefore better outcomes. If your starting time is 23 seconds before you're saturating less than 85%, then adding 40 seconds to 2 minutes is a significant amount of time and might mean the difference in a cardiac arrest. This is a meta-analysis that included 7 randomized control trials, a total of 959 patients, looking at the use of conventional oxygen therapy, high-flow nasal cannula, non-invasive ventilation, and non-invasive ventilation together with high-flow nasal cannula as pre-oxygenation before intubation in patients with acute hypoxemic respiratory failure. The primary outcome was the lowest SpO2 during the intubation procedure. Here's a chart comparing the different methods of pre-oxygenation. Patients pre-oxygenated with non-invasive ventilation had significantly less desaturation than patients treated with conventional oxygen therapy and high-flow nasal cannula. High-flow nasal cannula showed a trend toward being better than conventional oxygenation. In addition, the analysis showed that both non-invasive ventilation and high-flow nasal cannula had a lower risk of intubation-related complications than conventional oxygen therapy. They did not find a significant difference in mortality between the groups. We will have 4 bottom line points throughout the talk. The first is, don't underestimate the importance of pre-oxygenation. Use PEEP. Non-invasive ventilation is probably best. So when you arrive to the room and the patient is already on BiPAP or BiPAP is in the room, leave the patient on BiPAP for pre-oxygenation. Adjust the setting to 100% FiO2. If you're not using non-invasive ventilation, we would recommend bagging with a PEEP valve for pre-oxygenation. You can also consider using non-invasive as a method of pre-oxygenation. Now we will move on to discuss apneic oxygenation. Apneic oxygenation is the passive flow of oxygen into the alveoli during apnea. In healthy surgical patients, apneic oxygenation can provide appropriate oxygen saturations for extended periods of time. However, as we discussed earlier, the critically ill are much more likely to desaturate quickly. Here is a meta-analysis evaluating the effect of apneic oxygenation on the incidence of clinically significant hypoxemia during emergency endotracheal intubation. Clinically significant hypoxemia was defined as an SpO2 less than 90% in most of these studies. They concluded that apneic oxygenation reduced the relative risk of hypoxemia by 30% and had a trend toward lower mortality. There were 8 studies in the meta-analysis, but 9 included in the qualitative analysis. I'd like to point out the modes of apneic oxygenation here. 6 of the studies used only nasal cannula, anywhere from 5 to 15 liters per minute. And 3 of them used high-flow nasal cannula, 50 to 60 liters at 100% FiO2. This is a meta-analysis which evaluated high-flow nasal cannula as a method of apneic oxygenation in critically ill patients. It included 6 randomized control trials and a prospective study for a total of 956 participants. It showed that high-flow nasal cannula was non-inferior to standard of care during endotracheal intubation regarding incidence of severe hypoxemia, mean lowest oxygen saturation, and in-hospital mortality. In a subgroup analysis, high-flow nasal cannula significantly reduced the incidence of severe hypoxemia, which they defined as an oxygen saturation less than 80%, during intubation in patients with mild hypoxemia, which they defined as a P/F ratio greater than 200. High-flow nasal cannula during endotracheal intubation was found to be associated with a shorter ICU length of stay by a mean of 1.8 days. The bottom line here, apneic oxygenation with nasal cannula or high-flow nasal cannula might help and is unlikely to do harm. So if you arrive to the room and the patient is already on high-flow nasal cannula or regular nasal cannula, we recommend you leave it on during endotracheal intubation. And don't forget to have the respiratory therapist increase the FiO2 to 100%. What about mask ventilation? This is a study in the New England Journal of Medicine where they evaluated whether positive pressure ventilation with a bag mask device and PEEP valve during tracheal intubation prevents hypoxemia without increasing the risk of aspiration in critically ill adults. This study was a multi-center randomized trial in 7 ICUs in the United States. There were around 400 patients enrolled, and the primary outcome was the lowest oxygen saturation, and the secondary outcome was the incidence of severe hypoxemia, which they defined as an SpO2 less than 80%. Given that the severe hypoxemia and subsequent complications is what we're most concerned about while intubating, let's take a look at those results. As you can see here, only 10.9% of patients receiving ventilation had severe hypoxemia, defined as the O2 less than 80%, compared with 22.8% in the no ventilation group. The study showed a significantly lower incidence of severe hypoxemia in patients who received bag mask ventilation, and this reached statistical significance. Notably, there was no difference in operator-reported aspiration events, nor new chest X-ray opacity noted within 48 hours of intubation. And I'd like to again point out that the ventilation was done with a PEEP valve. This tells us that mask ventilation may be a powerful and safe tool to avoid severe hypoxemia when intubating critically ill patients. The bottom line, don't be afraid to mask ventilate during the apneic period. Your patient's risk of hypoxemia is likely higher than their risk of aspiration. Knowing how important pre-oxygenation is, what can we do when you are unable to safely pre-oxygenate a patient? Proceeding directly to RSI has multiple risks involved, and RSI may not be the best option. The term delayed sequence intubation is coined by Scott Weingard, an ED intensivist, and describes using ketamine prior to intubation in order to better pre-oxygenate patients who are unable to tolerate conventional methods of pre-oxygenation and who are at a high risk of desaturating. In this method, called delayed sequence intubation, patients who are not predicted to have an anatomically difficult airway and who are uncooperative after maximal attempts of traditional means of pre-oxygenation, which was defined as 3 attempts to facilitate standard pre-oxygenation procedure, are given ketamine to facilitate pre-oxygenation. Here they used 1 milligram per kilogram and an additional 0.5 milligrams per kilogram as needed to get to a dissociated state. Then they pre-oxygenated first with a non-rebreather, and if that wasn't sufficient, they used CPAP with a PEEP of 5 to 15 after 3 minutes, and then they paralyzed and intubated the patient. During pre-oxygenation, they may also have done other things such as place an NG tube, such as in a patient with a GI bleed. So here you can see the algorithm. The patient who was originally unable to be pre-oxygenated was given ketamine for dissociation. After about 10 to 15 seconds, they were then able to pre-oxygenate the patient. For 3 minutes, they used first a non-rebreather and then CPAP if needed. And 3 minutes later, they moved forward with paralyzing. They did use apneic oxygenation during their endotracheal intubation, and they moved forward to intubate the patient. Their primary outcome was the difference in oxygenation saturation, which is shown here. The blue dot represents each patient's individual O2 saturation despite conventional pre-oxygenation attempts prior to the ketamine. The red dot then corresponds to their oxygen saturation after ketamine and either a non-rebreather or CPAP. No patients had pre-muscle relaxant apnea, peri-intubation emesis, cardiac arrest, or death, and only 2 patients had their oxygen desaturations decrease, as you can see here. And this was from 99 to 98% and 95 to 93%. Of course, there were limitations. This was not a randomized control trial. It was small, and there could be selection bias. However, DSI, delayed sequence intubation, appeared to be an effective pre-oxygenation strategy, and there was no peri-intubation emesis. In summary, delayed sequence intubation is something you should consider in a patient that you are unable to pre-oxygenate effectively. Ketamine was used here, but you could consider other medications such as Ativan or morphine that would assist in calming the patient. Ketamine in theory doesn't blunt airway reflexes, but there is no clear data. I'd like to point out that there was no incidence of aspiration in this study, and there was an increase in oxygen saturation. Overall, the average oxygen saturation before delayed sequence intubation was 89%, and after ketamine and pre-oxygenation was 98%. In addition, there was no apnea, cardiac arrest, or death. The bottom line is to consider pharmacologic intervention if you are unable to adequately pre-oxygenate your patient. Now we have our 4 key points. Knowing how important pre-oxygenation is, we can improve our pre-oxygenation strategies with PEEP and apneic oxygenation. We can have a low threshold to mask ventilate during the apneic period, and if we have a patient with low oxygen saturations pre-intubation, we can consider medicating them to achieve appropriate oxygenation rather than proceeding directly with RSI. These are the recommendations from the Society for Airway Management for the physiologically difficult airway. As you can see, a lot of what we talked about today is reflected in their recommendations. 1, pre-oxygenation should be performed using high flow oxygen. They say for at least 3 minutes. 2, desaturation is the biggest risk factor for cardiac arrest. 3, they recommend pre-oxygenation with PEEP using non-invasive positive pressure ventilation for many pathologies. 4, they say pre-oxygenate in the upright position. And 5, delayed sequence intubation is an option for a patient who cannot tolerate pre-oxygenation with non-invasive positive pressure ventilation or high flow. And this recommendation was in 100% agreement. I hope this lecture has helped you to beat the clock and extend apnea time in your critically ill patients during endotracheal intubation. Thank you very much for your time.
Hi, my name is Alok Gupta, and I'm an assistant professor of anesthesiology and critical care at Northwestern University's Feinberg School of Medicine. Today, I'll be talking about pushing the poison, choice of the induction agent in critically ill patients. In terms of disclosures, I have a relationship with the National Heart, Lung, and Blood Institute, for which we are participating in a multi-center trial at Northwestern. There are no other relevant disclosures. Learning objectives. We've already talked about the complex interactions that take place at emergency airways outside of the operating room. And we've talked about patient factors and oxygenation. Now we're going to change course and talk about drug choice for induction and a brief review of some of the evidence behind that drug choice. In terms of guidelines for management of tracheal intubation in critically ill adults, the guidelines do lay out some challenges and propose some solutions of those challenges in the critically ill patient. Those challenges, they break into 3 sections. So those in terms of setting of being outside of the operating room, whether it's the intensive care unit, the emergency department, or on the floor. There are also patient factors, and there are staffing related challenges that can occur. If you look at all of these different factors that are laid out, only one of them addresses induction agents at airways, and that would be the cardiovascular physiology. So they acknowledge the unstable imminent collapse in patients before intubation and that standard drugs are problematic. They recommend pre-induction optimization and that ketamine is recommended, as well as the proactive use of inotropes or vasopressors. Diving deeper into the guidelines, you see that they recommend a vasopressor or inotrope immediately available for bolus or infusion during induction and intubation. Additionally, a vasopressor should be considered before induction. And again, the recommendation of ketamine, as it produces less cardiovascular instability as compared to propofol or thiopental. And etomidate-induced adrenal suppression is a reason why this drug should not be used routinely in critically ill patients. The authors also acknowledge the effect that positive pressure ventilation with large tidal volumes, a high respiratory rate, or high peak can have on cardiovascular physiology. If we look at the recommendations for the physiologic difficult airway, they mention that physiologic derangements predominantly drive risks with intubation in this population and often precipitate complications despite first pass success. And it's really those iatrogenic alterations to patient physiology through induction agents and resuscitation strategies that contribute additional risk. If we look back at the INTUBE study, and they talked about the complications that can occur during peri-intubation, the major adverse events, cardiovascular instability was at the top of the list. And when we talk about cardiovascular instability, it really comes down to hypotension. In the physiologic difficult airway paper, they discuss strategies to avoid perioperative hypotension. This includes fluid resuscitating the patient before intubation, vasopressor infusions started before intubation in patients who are not volume responsive or fluid tolerant. And if vasopressor infusions are not available, then bolus dose vasopressors should be available to help maintain systemic pressure during and after intubation. In terms of induction agents, they just mentioned that hemodynamically neutral induction agents should be used, and 100% of anesthesiologists can agree on that. So what about our choice of induction agents? So when we talk about induction agents, we really have a few available to us. We are all familiar with this chart looking at the physiologic effects of various IV anesthetics. I have blocked out thiopental here, given its lack of clinical use in the United States. So if we look at propofol, etomidate, and ketamine, we can see that etomidate is really the most stable in terms of systemic vascular resistance, its effect on mean arterial pressure, as well as cardiac contractility. By this chart, that would make etomidate really the ideal choice of induction agent for emergency airway management. However, there are a lot of controversies that exist around etomidate, and I can really think of no other drug that is as controversial as etomidate. In this multi-center randomized controlled trial, 655 patients were randomized to receive either etomidate or ketamine, and the indication for intubation was largely mental status. Some were respiratory failure. The primary outcome was the maximum SOFA score. And in terms of outcome, there was no difference in SOFA score, nor in mortality or ICU length of stay. In 2015, Cochrane performed a systematic review in patients who received etomidate for induction as compared to other agents for endotracheal intubation. And they found no conclusive evidence that etomidate increases mortality or healthcare resource utilization in critically ill patients. They did, however, mention that it does seem to increase the risk of adrenal gland dysfunction and multi-system organ dysfunction by a small amount. However, the clinical significance of this adrenal suppression is really unknown. In a more recent meta-analysis, looking at etomidate, adrenal insufficiency, and mortality, you can see here that this included 29 trials with about 8,500 patients. Etomidate did have an increased risk of adrenal insufficiency and an increased overall relative mortality. However, with further analysis, there was a continuous progressive relative risk of mortality with increasing severity of illness. That is, in those patients who had a predicted pre-intubation predicted mortality of greater than 44%, those patients really were at increased risk of mortality with etomidate as compared to those who had a predicted mortality of less than 44%. So if we go back to the INTUBE study, and there were some letters to the editor regarding that study, that in this study, intubation itself was unlikely to be the cause of cardiovascular instability, which developed in about 40% of patients. Instead, it was the administration of propofol, the sympatholytic induction agent that caused hypotension, and that was used in about 40% of patients. Another letter stated that we believe the authors omitted an important discussion about the possible adverse effects of rapid sequence induction, which was used in about 60% of patients in this study. And it's well known that rapid sequence induction can greatly contribute to hemodynamic and respiratory collapse in critically ill patients. The authors responded by saying that propofol was not significantly associated with the primary outcome of major adverse peri-intubation events. However, they could not exclude a negative effect of propofol in patients with underlying hemodynamic instability. But they did not observe an association of muscle relaxation and major adverse peri-intubation events. In this recent study published last year, looking at propofol, ketamine, and etomidate as the induction agents for intubation and outcomes in critically ill patients. This was a retrospective, single-center cohort study of consecutive critically ill adults. They each received only one IV anesthetic agent. Induction agents were propofol, ketamine, and etomidate, and about a third of patients received each of those medications. Overall ICU and hospital mortality was about 19% and 29% respectively. Patients given ketamine had higher odds of ICU mortality. Those given etomidate had higher odds of ICU mortality, hospital mortality, and had fewer ICU free days as compared to those given propofol. However, patients given ketamine and etomidate had similar odds of hospital mortality and similar hospital free days. This led authors to conclude that propofol was associated with a better outcome in critically ill patients undergoing anesthesia for intubation. What about dosing? One could really argue that dosing is more important than the choice of induction agent. Critically ill patients are often preload dependent, and all agents will lower blood pressure in patients dependent on their sympathetic drive for survival. We've all seen those patients who have received very minimal doses of anesthetic agents and after intubation have cardiovascular collapse. In this study, where they looked at dosing, the hemodynamic effects of intravenous etomidate versus propofol using an entropy-guided hypnosis levels, they randomized 60 patients to propofol or etomidate and titrated that dose to an entropy level of 40. However, in this group, there were elective cases, there were ASAs 1 and 2, they were given midazolam and fentanyl pre-induction and alprazolam the night before surgery. So this is not the critically ill patient population. However, they did show that in this otherwise healthy population, that if you titrate slowly, you could reduce the amount of dose in patients. So does this translate to the critically ill population? We don't have that answer. But what else can we do? What about fluid boluses? So in this study from 2019, where they looked at the effect of a fluid bolus on cardiovascular collapse among critically ill adults undergoing tracheal intubation, what they did was they gave a bolus of 500 mLs of crystalloid to patients before intubation. About 168 patients received fluid bolus. There were various diagnoses of the patients, and the indication for intubation was overwhelming hypoxic respiratory failure. What they found was that an administration of an intravenous fluid bolus did not decrease the overall incidence of cardiovascular collapse during critical intubation of critically ill patients compared to those who did not receive fluid bolus. And what they looked at was new or increased vasopressor, systolic blood pressure less than 65, that's new, cardiac arrest within 1 hour, and death within 1 hour. And looking at all 4 of these variables, there was no difference. However, when looking deeper at the data, they did find that a fluid bolus administration appeared to decrease the risk of cardiovascular collapse among patients receiving pre-intubation positive pressure ventilation. And it appeared to increase the risk of cardiovascular collapse among patients not receiving pre-intubation positive pressure ventilation. There is now the ongoing PREPARE 2 trial that's looking at the benefit of bolus between induction and laryngoscopy in patients undergoing positive pressure ventilation. So in summary, we're looking at the choice of induction agent, whether it's etomidate, ketamine, propofol. The data is really all over the place. And I think that any of those drugs could be used safely as long as we keep in mind the risks in these patients and use vasopressors as needed, as well as try to optimize patients from a fluid level. You know, the other thing we need to do is possibly rethink our priorities when we're intubating critically ill patients. If you have a crashing patient, you know, I'm happy if they can tell me that they remember the intubation, because that means they're alive at the end of this. So we need to rethink that. This is Weingarten-Nixon's hierarchy of resuscitation airway needs. Thank you very much.
I'll now wrap up with some concluding thoughts based on what our 3 panelists have presented. The first is that outcomes in emergency airway management have been relatively slow to change over the past 20 years. We've come to appreciate how the demographics, anatomy, and physiology of these patients all conspire to make airway management more challenging than it would otherwise be, such as in an operating room setting. Secondly, physiologic compromise really elevates the importance of first-pass success during emergency airway management. One means by which to facilitate first-pass success is the application of advanced techniques that safely extend the apneic interval. Third, all sedative hypnotics have the potential for hemodynamic trespass. However, apart from therapeutic nihilism, we should instead embrace the fact that each of them have their own unique pros and cons. So let's summarize some of these concepts into steps that are necessary for success. The first is to recognize that critically ill adults are at risk for adverse events during emergency airway management. The second is that we therefore need to apply rigor in our individual and in our systems-based approach to these sorts of encounters in the intensive care unit and in other out-of-OR airway management settings. From an anatomic standpoint, we need to plan for the fact that these airways may be more challenging. This is something that comes very naturally to us as anesthesiologists. On the other hand, we must not forget to plan and prepare for physiologic difficulty. We have to take steps to mitigate this ahead of time and to recover from it when it does happen. And last but not least, I also want to highlight the importance of spreading the word about how airway management in critically ill adults differs from that in other individuals. Take this to your institution, take this to your peers, take this to your colleagues, take it around the world and help to protect these patients who are vulnerable. Thank you for your attention and for your interest in this topic. It'll be our pleasure now as a panel to address any questions that you might have. All right, fantastic. Well, I'm going to take a look over at our chat, and we've got a few questions that were carried over, and I'm just going to take them in the order in which they came. So first question for our panelists, can anybody comment on the use of awake intubation for the anatomically normal but hemodynamically collapsed patient to avoid abrupt induction, abrupt hypotension with induction and positive pressure ventilation? Comments on that?
I can take that one. So in terms of some of the outcome studies that were done before the study, they actually did look at patients who didn't get any induction medication, and almost half of the cardiac arrests were patients who received no induction medication. So I think it makes sense intuitively that not giving something that could cause cardiac collapse was beneficial, but I think these patients are just so tenuous that even positive pressure, as well as the, you know, picking up the breathing, all of that still is enough physiologic stress that they're at high risk. I have not seen specifically updated studies on that. Those were all done sort of early 2000s, late 1990s. So I do think it's worth looking at, but I wouldn't treat it like that's a definitive way to maintain it.
Rachel, was there anything you wanted to add? And then I can chime in my 2 cents.
I might have been having some technical difficulties hearing her, but I would agree with everything that Dr. Jarzabowski says.
I think the only thing that I will add is that you know, I think sometimes as, you know, anesthesiologists and, you know, in Dr. Cater's case, emergency medicine physicians, you know, we're familiar with how to do awake intubation, right? It comes very naturally to us. We've trained in how to do it. We've done a bunch of them. And I think one of the challenges in trying to develop evidence-based guidelines that are broadly applicable to the practice of critical care, right, is that the practice is multidisciplinary. And, you know, people may be practicing critical care who are not familiar with how to do awake intubation. So, you know, I think that clinically it makes a lot of sense, right? You know, if you can transition someone over to positive pressure mechanical ventilation, you know, gently, or if you can keep somebody awake and have them participate in their own mechanical ventilation and have some degree of negative pressure, I think that that is helpful. But the problem is, I think, in developing evidence-based guidelines, it's an issue of translation, right? Translation into practice becomes challenging. Oh, great question here about POCUS. So from Tim. So how often do you do POCUS pre-intubation where fluids may be harmful? So for an example, pulmonary embolism, RV failure, that sort of thing.
I can take that one since I do quite a bit of POCUS. I do very frequently complete POCUS exams, at least on all my patients in the ICU, so that I have a good idea of their fluid status. In that instance, then I can better set up to say that fluids might not be the best intervention for this patient, and I can move forward to starting some vasopressors and maybe even help me decide which vasopressor. For example, if I have RV failure, I'm more likely to start a little epi to kind of help out the RV as well. In a patient where it's a floor patient where I'm going just to do the intubation and I might not have time, then I'm certainly focusing on my pre-oxygenation, and I will just blindly give the fluids. I don't usually hold off the intubation to do POCUS, but if they're already in my ICU, then I'm usually somewhat familiar with their POCUS exam because I've recently done one.
All right, I don't want to open up a POCUS can of worms, but I'll ask a follow-up question real quick. What's your favorite POCUS measure for volume responsiveness?
My favorite for volume responsiveness, I do like to look at the IVC. My favorite protocol of fluid resuscitation looks at 1.5 to 2.5 being considered kind of the normal range of the IVC. Greater than 2.5, less likely to be fluid responsive. Less than 1.5, definitely fluid responsive. Problem is 1.5 to 2.5 is a huge range. And so I'm also oftentimes looking at the LVOT VTI, the velocity time and integral, and taking a look at what is that. And then if I give them fluid, is that increasing? Kind of like a fluid test. But both of those, in addition, of course, with the entire clinical picture and the other information I have, I think is helpful.
Makes sense. All right, hello, welcome. You know, maybe a question for you. So I'm going to carry this over from the other platform. So I guess to summarize, there was a little bit of chat in the other platform about you know, I guess for lack of a better word, indication bias in some of the retrospective clinical outcomes research that's done about induction agents. So if, for example, you're worried about hemodynamic collapse or you're worried about the patient's cardiac function, you know, you may obviously try to select something that's, you know, perceived to be a little bit more stable than, say, propofol. So, you know, I think that one of the challenges for us in trying to interpret that literature and figure out how it applies to our patients and then actually how it should change our clinical practice is how it is that we should interpret some of the retrospective literature when there's an inherent risk to selection bias, which is a difficult question, but anything to add about that?
Sorry, just unmuting. No, I agree with you completely. I think it is very difficult to interpret the literature because, you know, I work primarily in perioperative ICUs, whereas a lot of the literature is not necessarily just from perioperative ICUs. And so different patient populations obviously can make a difference in that. But also I have found that a lot of institutions are very culturally different. in terms of what they use. Some places only use propofol, some places only use etomidate. And so I think that definitely confounds some of it also. As you know, it's really hard to do a prospective study on this, although I guess it could feasibly be done, but each patient is very difficult. So I think it is kind of up to us to interpret the retrospective studies that are out there and decide what works best in each patient situation.
I'll ask maybe a practical question for the panel. Just the other day, I was doing some airway management in the ICU, and the patient was on heated high flow nasal cannula. And I said, wow, this is super convenient. We're going to turn this up to 11 and we're going to continue it. And a situation arose where I needed to apply positive pressure ventilation with a bag. And I said to myself, man, this nasal cannula is really in the way now. I wish maybe I should have done something a little bit differently. So I think one of the things that I'm always wondering about when I'm trying to think about, apneic oxygenation techniques, is how I can best accomplish those with the nasal cannula, when there's also the chance that I may need to try to manage the airway with a mask in a bag. Thoughts about that?
I can take that to start with. I think, of course, it's going to affect your mask seal if the need arises to mask ventilate. I have successfully achieved a pretty good seal with 2 hands and extra people who are all on board with what we are doing. So my usual kind of method is to tell the respiratory therapist and whoever's there as my second pair of hands, they're going to try this with nasal cannula, the high flow on. If I need you to take it off really quickly if we're not achieving a seal, and you're going to be the person who bags, I'm going to be the one who's holding the mask, or just clearly delineate roles. But it's definitely an obstacle if you're trying to mask ventilate. I don't know if anyone else has other techniques.
I think the one situation where I've come into issues with that is when we were doing an emergency airway, not necessarily in the ICU, but on the floor, and there weren't enough oxygen hookups in the room. There was, I think it was the ED, the patient was on high flow nasal cannula, and there was not enough oxygen hookups for them to then get a ventilator or whatnot. And so that became a little technically challenging. But I do prefer to keep the high flow nasal cannula on as long as we possibly can.
All right, a quick clinical practice question for everybody. So we have a question here. Imagine you have a patient, they're comatose, sick, vasopressors, fluids, all of those things. In these instances, is your personal practice to avoid the use of sedative hypnotics and instead, for example, blunt the sympathetic response with a short-acting opioid and facilitate neuromuscular blockade, or facilitate airway management with neuromuscular blockade only? It's a little bit of a controversial question. I know some people think you always need a sedative hypnotic to do airway management. Others disagree. What do you all think?
I can start off with that one. So I tend to be in the disagree camp, that if the patient is not, conscious, or, especially obviously during a cardiac arrest, that I try not to give medications if I can. Sometimes I have found, though, that in that patient with the low GCS, that their mouth may be difficult to open. And so in case I will need a neuromuscular blockage, intubation. In those situations, we'll give small doses of hypnotic, 20, 30 milligrams of propofol, just to facilitate, me giving the neuromuscular blockage.
All right, hearing no dissenting opinions, we'll move on to the next question. So I think this is a really thought-provoking question. I know it's something that I've wondered a lot about. So the question broadly pertains to the expansion of video laryngoscopy over the years, and whether or not that could be degrading skills in conventional laryngoscopy, or whether or not it could be luring people into a false sense of confidence that, oh, we have video laryngoscopy, I can visualize the glottic aperture so easily now, right? Ergo, all airway management is easy. Thoughts on this subject? Again, relatively controversial.
Yeah, I think the role of video laryngoscopy is very controversial. There's been studies on both sides of that argument showing, more severe adverse outcomes when video laryngoscope is used, which is surprising because, I think it really has been a valuable tool. I think a lot of those studies looking at video laryngoscopes are highly subject to very different operators. So one coming to mind, there was a head-to-head study of direct laryngoscopy to video laryngoscopy, and it was using, I think, first-year pulmonary critical care fellows as the operators, and they weren't allowed to paralyze. So obviously the group that got the video laryngoscope did better. They could see something. Or I can't imagine doing new airways as a relatively new operator without any paralytic. Seems kind of counterproductive. But so I think the video laryngoscope does muddy the waters. I don't know that it really has contributed necessarily to technique issues. If anything, I think it's a reflection on perhaps our focus has been on the wrong thing in terms of outcomes. There's a lot of focus on first pass success, and maybe that some studies show gets better with a glide scope, but who cares if your patients in cardiac arrest 10 minutes later. So now that we have kind of a renewed focus towards hypoxemia and hemodynamic collapse, I think hopefully we'll start to see some more targeted studies about specific populations. I think one other question in the chat was about, who were these patients? Were these in heart failure? Were these septic patients? And the truth is it's all heterogeneous. Most of these studies are incredibly heterogeneous. So it's very hard to draw meaningful conclusions. So hopefully we'll start seeing, better outcomes data related to specific populations and specific techniques going forward.
Yeah, if I could just chime in, I mean, we all work at major academic centers, right? We don't have a lack of resources. At every Airway, we have, 4 respiratory therapists. I'm exaggerating a little bit, but we get a glide scope, we have a fiber optic, we have all of those things. But I always stress trainees because it is easy for them just to go to a video laryngoscope. But what if that patient was having hematemesis or vomiting, right? Then video laryngoscope is not going to be useful in this situation. So we really have to think about using direct laryngoscopy and getting the practice in those situations.
And I'd also like to chime in and say, from an emergency medicine standpoint, is particularly if you're doing community emergency medicine, you might not have VL available or working. And so we, from a training standpoint, do try to push that you don't want to lose your DL skills, not only for the clinical scenarios that Dr. Gupta mentioned, but just if you're in a situation where it's not charged, it's not working, and you don't have that equipment, it's always good to do both.
All right, we'll allocate a couple of seconds to a question here from Kunal, which I will summarize as follows. What about combining sedative hypnotics? Propofol and ketamine, propofol and etomidate? Pick your combination of poisons. Thoughts on this trend?
So we do this all the time in the emergency department for procedural sedation, and I absolutely love it, but I've never used it personally for induction, nor have I seen it necessarily used in a lot of studies. So I'd be curious to see what you.
So we discourage the practice, well, especially, speaking of probably one of the more common ones of combining ketamine and propofol. For us, at least, it's difficult to get ketamine at emergency airways, given that it's a controlled substance. And then our pharmacy with new regulations, if we mix them in a syringe, we're technically compounding, which we're not allowed to do. But I've never combined propofol with etomidate personally.
Either. I'm curious what the advantage is there. Less propofol, more etomidate, and just use etomidate, or I don't know. I'd be curious to know more about that. Also, I think the importance of reducing your dose is so important that rather than combine it with another agent, I would just pick a lower dose of the agent I wanted. But I'd be very interested to hear more if people have studies or even anecdotes about those. And calling it propidate is pretty good. I like that, Kunal.
I guess I'll chime in briefly. One of the challenges that I've seen with combining of sedative hypnotic agents is it can lead less experienced clinicians into a false sense of security. It's like, oh, I'll just give 60 milligrams of propofol and 60 milligrams of ketamine. And the next thing you know, wow, you've given a lot of sedative hypnotic agent and the patient is now hypotensive. So sometimes I think you've got to be careful sometimes with those combinations. And I'm going to agree with Dr. Wall here in the chat that norepi is a really great sedative hypnotic agent in emergency airway management. We've got, I guess, a few more minutes here. Maybe we could just, I'll kind of propose one more question to the panel and then we'll wrap up. So I'd like to hear, I guess, from each of the three panelists, if you could arm people with one, really relevant take-home point that you would like them to go back to their, places of practice with and to kind of disseminate out, what would that be?
I can go first since I went first in the talk, that this is the most dangerous procedure we perform and needs to be taken seriously. Oftentimes it's like a grumble groan, there's a code that we're called to, but really this, it doesn't get more dangerous than this. And to put it in perspective, in the US today, I think the entire 30-day perioperative period for a cabbage surgery, the mortality is less than 1%. So in a 30-minute window, we are doing something far riskier to these sick patients than something we would consider highly risky, open heart surgery. So take it seriously and be involved and follow the literature, because I think we're finally getting somewhere.
For me, I think it would be, oh, sorry, can you hear me? Oh, sorry. I think it would be pre-oxygenate, pre-oxygenate, pre-oxygenate. I think just realizing how quickly these patients will desaturate and how deadly that can truly be if we don't focus on their oxygen saturations. And in a lot of times, in anesthesia, we focus on aspiration, but kind of knowing that in this time, oxygenation is more important potentially. And, using whatever methods you can use, BiPAP, high flow, keep it on during intubation, use a PEEP valve when you pre-oxygenate, whatever you can do to kind of increase those oxygen saturations and increase your time to desaturation.
And I think my takeaway is that probably the choice of sedative hypnotic we use doesn't matter as much as the dose that we use. These are already critically ill patients. And so doing dose reduction is probably what's going to make a bigger difference in outcomes in the patients.
And if I could chime in one more about the key to fall talk, I think the reason I see that we probably use it a lot in the ED for our procedures is we need the patients to be heavily sedated. If I'm going to reduce a hip, I need them to be quite sedated. And so I have to increase my dose of propofol. And therefore I'm increasing that to the point where then ketamine can kind of help with the hemodynamics associated with that. Whereas, as Dr. Gupta pointed out, we can, when we're intubating, just decrease our dose. We don't need them completely sedated as we're doing a reduction or something, because they're already critically ill and maybe not quite aware as well.
I think one of the hardest things sometimes about trying to reduce or forego the dose of sedative hypnotics for airway management is managing the expectations of the team, right? It's like, oh my goodness, you just did this to this poor person and you didn't give them anything to make them sleepy. It's like, well, they're comatose at present, so that may not strictly be necessary. All right, well, with that kind of humorous anecdote that I think we can all relate to, I will thank all three of our panelists, Dr. Jarzabowski, Dr. Kedar, and Dr. Gupta for their time and for their expertise. And thanks to everybody who joined in for the Q&A, and hope you enjoy the remainder of IARS. Thanks, everybody.